Now let's start the second video of neovascular glaucoma, and in this video we will discuss its management. In the first video we have discussed the pathogenesis, why retinal ischemia causes neovascular glaucoma, what are the normal iris vessels and what are the properties of abnormal new vessels. So management usually starts with the history, and such patients will give you a history of diabetes for long time, especially more than 10 years duration, and they will also give you history of monthly anti-VEGF injections and laser photocoagulation that will point towards the proliferative diabetic retinopathy disease. And when you examine the other eye, it will also have diabetic retinopathy. So the other patient will give you a history of sudden painless loss of vision 3 months back, and the other eye will be normal, and that will give you a hint of ischemic CRVO related neovascular glaucoma. And the other patient will have significant carotid artery occlusion, more than 90% on the same side, and raised intraocular pressure. So that will point towards ocular ischemic syndrome related neovascular glaucoma, intraocular tumor, history of irradiation, that all carotid cavernous fistula, that all will point towards the cause of NVG. So the treatment of neovascular glaucoma depends upon the stage of presentation, that at what stage the patient has presented to you, how much is the vision, how much is the pressure, and how much is the pain. So in short, you have to treat those three things. You have to treat the retinal ischemia, that is the most important thing. You have to treat the raised intraocular pressure, and you have to treat the pain of the patient. So these are the three pillars of the treatment of neovascular glaucoma. Now if the patient presents at stage 1 with a prerubiotic stage, the patient will have a good vision, the patient will have a normal intraocular pressure, you will not be able to observe vessels in the angle or on the iris. But if you get a clue that the patient have got severe retinal ischemia and you treat that ischemia, then neovascular glaucoma will never happen. And few people think that you don't need to treat retinal ischemia at that stage, and you have to observe. But closely observe such patients, and as soon as rubeosis appear on the iris, then go for the aggressive treatment. So when rubeosis appears with a normal intraocular pressure, good vision, and no pain, treat the retinal ischemia with extensive pan-retinal photocoagulation with adjunctive anti-VEGF injections, and if there is a problem with the retinal view, cryo can be done as well. So it will also decrease the VEGF signals for neovascularization of anterior segment. So as soon as retinal ischemia is controlled, rubeosis will disappear before advancing to the stage of raised intraocular pressure. Now if the patient present a bit late at secondary upper angle glaucoma stage, then the patient will have a poor vision, the patient will have raised intraocular pressure, and the patient may or may not have pain. So you need again to treat retinal ischemia, the basic pathology, with again extensive pan-retinal photocoagulation and anti-VEGF, but also now you need to lower down the intraocular pressure with aqueous suppressants like beta blockers, alpha agonists and carbonic anhydrase inhibitors, because elevated intraocular pressure is due to compromised trabecular function. Now some people argue that prostaglandin analogs should be avoided because they incite inflammation, but we have not found much evidence, and as neovascular glaucoma have got high pressures and prostaglandin analogs are added to aqueous suppressants to control IOP. And topical steroids and atropine cycloplegics are also added to the treatment, and it is one of the angle closure glaucomas, this neovascular glaucoma, in which atropine is given as a treatment. Otherwise atropine is contraindicated in a routine angle closure glaucoma. So if glaucoma reaches secondary angle closure glaucoma stage, then it is less likely that it will be controlled medically. And if vision is 660 or around 660, then you need to go for the surgical options to control the pressure. Then you can perform trabeculectomy with mitomycin C, or you can put glaucoma drainage devices. Now in the setting of active neovascularization, in order to avoid intraoperative and post-operative bleeding, then aqueous shunts are preferred, whereas in a quiet eye with a good posterior segment view for PRP, then trab is the preferred choice, because trab will control pressure more, and trab can be done within a week of anti-VEGF injection to decrease the chances of bleeding. Now in the absolute glaucoma painful blind eye stage, when there is a pain, raised intraocular pressure, and there is no salvageable vision, good vision, then cyclophotocoagulation is done. You have to damage the ciliary body. So for that we have got cyclocryo option as well as diode laser. So DLC, diode laser cycloablation, is the preferred method than cyclocryotherapy to avoid hypotony and phthisis bulbi. So in summary, we need to treat many things in prerubiotic glaucoma according to the stage of the disease at presentation. You need to check the vision. If vision is good, pressure is normal, and there is no pain, it means just treating retinal ischemia can treat the disease. If vision is poor, there is raised IOP and no pain, again you have to treat retinal ischemia and medically raised intraocular pressure. And if there is painful blind eye, then you have to give oral painkillers. You need to treat retinal ischemia, and you need to control intraocular pressure first medically and then surgically. So neovascular glaucoma is a quite complex disease, and I have told you the basic theme of treating neovascular glaucoma, that you need to treat three things. You need to treat the pain, you need to treat the pressure, the raised intraocular pressure in the form of glaucoma, and you need to treat the cause, the retinal ischemia. And that's how you goes. So I hope I have discussed much of the things, and after watching these two videos of neovascular glaucoma, you will be able to know the pathogenesis and how to treat it. Thank you very much.